Okay.
This is cheat sheet.
So, today the plan is to cover diabetes and the first section of cardiovascular stuff. So, are there any major concerns about the exam that you just took? Like any big concepts that you think you missed or would like to review?
I don't know. The only
Yeah.
one I was annoyed, that question I was annoyed with was, it was like number 20.
Yeah.
It was like Cushing's, Conn's, Addison's, or the
Theos.
yeah.
Okay, yeah.
And like I feel like I knew it. I just
I never even heard of that. The last one.
It was like
It was-
a
random
slide.
slide.
It was like,
Yeah.
very last slide of
Yeah,
the
it
PowerPoint.
was.
All I
Yeah.
wrote about it was attack the bear, because that's how he described it, was attacking the bear.
Yeah, so that one is all about like increased adrenaline to the point of like anything that, spooks this person can cause like this major response.
okay.
Yeah. So,
Oh, the other one that I got wrong, which I was kind of frustrated by, was I don't remember the question. I don't have my test with me, but it was like the IgE, IgG, IgE.
That
Oh, yeah,
one,
I think
yeah.
the last one.
That made me so mad.
I don't know what the question was. Does anyone know?
Whatever
It
it
was
was,
the mucosal, like what's secreted from the mucosa.
Malt.
Yeah,
Malt. That was it. I never heard of malt.
and it was
That's
like
like,
it was like
gut
IgA.
bacteria.
Right?
Yeah.
interesting.
Do you know malt?
Not too familiar with
Was
it.
it in our notes? Is malt ever?
No, well, if it was, I never
It's
saw it.
number 12.
I just, the only reason I knew it, or
Plasma
I didn't
sounds.
know
Was
it,
it
but I
GI?
guessed the way I did. Because it was
Yeah.
mucosa, which tends to be like your respiratory, your GI, your GU.
Right. Yeah.
So
That
that's
makes
the, I mean,
Yeah, the only.
I understand what, like, how I could have put something completely different.
Yeah.
Yeah, I think he talked about malt and galt. Like, I want to say, or maybe this is from another class, but it was like malt and
Yeah,
galt
the
was
two
very
names,
similar
yeah.
in terms of like when, like GI
Yeah.
kind of stuff. So that's
Right.
the only reason I knew it, because either he briefly said it or I heard it in
Mhm.
another class.
Not everything.
Yeah.
Oh, sorry. Here.
Also,
Oh, for the second one. Oh, nice.
okay, so if you guys have any other more specific questions on the exam, just email me and then I'll email back and it'll be fine. Okay, so moving on with insulin action and diabetes, all of that stuff. I guess the biggest thing about exam 2 is you're gonna have a lot of heart stuff. He likes to talk about diabetes for the exam, and you'll kind of get like a very quick rush of some pulmonary and some renal kidney stuff towards the end, and that can feel very rushed. So my biggest suggestion is that like with this cardiovascular stuff, try to absorb as much of it as possible, because I think like these are the ones that can be pretty easy to get as long as you understand major concepts about like heart circulation and things like that. Whereas with the kidney and the pulmonary, most of that I think is kind of like memorization, or just because I feel like those lectures being right before the exam like definitely make you feel kind of rushed in terms of learning it very solidly. So yeah, just do your best to try to keep up with the material as it starts to pile on. Okay, so insulin. Insulin is secreted after you have meals and after you have that glucose that enters the system, and so insulin tries to kind of package it away into your muscle and your fat cells, and those are your quote unquote glucose sinks. It's where all the excess glucose is going, because you don't really need it circulating around the system constantly. And then you store glucose as a molecule called glycogen. And then when you want to release glucose, you break glycogen. So glycogenolysis, to break it up into free glucose. So it's important to know the difference between when you have insulin versus if you don't have insulin. So when you have insulin, that's like after you've eaten. So you'll tend to try to decrease your appetite because you're full, you've just finished eating. Glucagon is kind of the opposite of insulin. So what it does is it is the molecule responsible for breaking up the glycogen to become glucose. So it has the opposite effect, whereas insulin stores glucose as glycogen. And so you can increase like this, fat synthesis, glycogen synthesis, glucose uptake by the cells. Also, you have a very weak bit of protein synthesis that comes along with it, but that's not like a major function. And then when you don't have insulin, so think when you're not eating, you kind of have to increase the appetite, you increase the amount of glucagon because you're low on glucose and you need more energy in the system. So at some point you can also start to break down the glucagon and start to kind of break at the muscles to get more glucose released. You can break down proteins, and you can also have this thing called ketoacidosis. So if you remember in the acid base, we talked about diabetic ketoacidosis as being one of those metabolic acidosis situations. So if you don't have much glucose in the system, at some point you might be breaking down fats to produce these ketone bodies as a form of energy. And with these ketone bodies, they can become acidotic to your system, and then that's just kind of like the acid-base kind of questions that go along with it. So in general, with diabetes mellitus, you've got type 1 and type 2, but they're very, very different. So type 1 is the one that, you get it very early on. It's, it's inherited, and it's pretty genetic, but it's not really inherited between twins, which is kind of the interesting portion of it. Whereas type 2 is more, you see a lot of twins having type 2, but it's not really the genetic reason. It's more of like an environmental reason that you would have it seen between two twins. So type 1 is important because it's your islet cells that are actually secreting the insulin. You're actually attacking them. So you break down the pancreatic islet cells, and so you can't make insulin. Whereas type 2 is completely different. So type 2 is because your cells do not actually respond to the insulin that you made. So your islet cells are fine. You make the insulin just fine, but the cells themselves do not respond normally to the insulin. So you might see like an increase in blood insulin levels with no corresponding effect, and that just goes along with type 2. Also, gestational diabetes, it is a quote-unquote undiagnosed form of diabetes. So in pregnant patients, if they show signs of diabetes, they just call that gestational. And then after they give birth to the child, like typically it can just go away. But if it sticks around, it might, it may or may not lead to formally being called type 2 diabetes. But it's just like a difference if like a pregnant person has the diabetes. It's just gestational because of like different metabolic factors that kind of upset like general balance and stuff. Also note diabetes, there's another thing called diabetes insipidus, whereas this diabetes is mellitus, so they're completely different. So diabetes insipidus is all about a defect in water reabsorption in the kidneys and is completely unrelated to this blood glucose diabetes mellitus. So again, with type 1, think the juvenile diabetes. So your immune system produces anti-islet cell antibodies that are actually attacking these beta cells of the pancreas. So it's an autoimmune disorder with a genetic predisposition. So you can still make glucagon and stuff like that, but you just have very low insulin levels like always. For type 1, it's part of the type 4 hypersensitivity, because it's like an autoimmune attacking the beta cells, and you typically don't have any clinical symptoms arising until sufficient destruction of those beta cells has actually occurred. With type 2 diabetes, on the other hand, again, it's adult onset. So your cells are just resistant to insulin, so you see an increase in insulin, but your cell's not responding. So you see this kind of general chart of how the insulin levels are changing in the body. So at first you think like, oh, okay, maybe if I use more insulin, like my body will react, but because the body isn't really reacting, you kind of figure out that like, oh, you don't need to keep making as much because it's not going to react anyways. So there is like this initial peak with the insulin production, and then it starts to go back down. And then again, gestational diabetes it can become type 2 diabetes after giving term. So again, type 1, you can't produce insulin. Type 2, you produce insulin but no effect. And this picture is just showing like where it affects it. So like pancreas, type 1, like don't actually produce the insulin. Type 2, the actual tissue itself does not respond. You can also have this thing called the oral glucose tolerance test. And so with this test, you give a patient like basically sugar water, and then they drink it, and then you chart how much glucose is in their system. So if they have diabetes mellitus, then their glucose levels won't really decrease, and it remains abnormally high kind of the whole time. In normal patients, you kind of increase, and then you actually drop below a baseline value before returning to normal. And then you have this other thing called the HbA1c glycosylated hemoglobin value, and that's also another indicator to tell like how much glucose is in the system and like how healthy or unhealthy like a certain patient is. And so typically it can give a lot of insight into the current state of the glucose levels in the system for a patient who's been diagnosed with diabetes. So there's also a bunch of different complications that go along with diabetes. So with type 1, you might have hypoglycemia because you have a low blood glucose in the system. You might have the diabetic ketoacidosis because you're not able to store the glucose very well, and you also like break down fats for energy. And then there's this other thing called the hyperosmolar hyperglycemic non-ketotic syndrome, or HONK, or HHNKS. And I believe this might be one of your clinical cases. So it's with these kind of patients, just note like there's a high osmolarity that you see, and this is associated with type 2 diabetes. And it can be just very bad for the patient overall. Like at some point, the high osmolarity kind of needs water so badly, like it starts to take away from vital organs and stuff. Chronic complications, though, you could have hyperglycemia in some cases. You could have diabetic retinopathy, so blindness, nephropathy, kidney damage, cardiomyopathy, heart damage. You can also have coronary artery disease, peripheral artery disease, or stroke. You also might see this thing called the polyol or sorbitol pathway, and you could have increased activity of that pathway, and one of the things that results is diabetic neuropathy. So your Schwann cells that myelinate your cells, like your axons, they actually aren't really getting properly myelinated because you're damaging those cells, and then so you're not actually carrying signals with your axons very well, and this can lead to blindness, and you can also have cataracts. And then also other things that may come up are glaucoma, which is another form of blindness, and other forms of infection. And so again, type 1, autoimmune. Type 2 is you can make the insulin, but it's not effective. So that was actually pretty quick. It's like with the diabetes stuff, it's short, but I feel like it comes up more with the clinical cases. Like you'll see a lot of things that just say like, oh, this patient has XYZ. And And I think like as long as you know the major differences between type 1 and type 2, like that's kind of like the major takeaway, I would say. So with the first unit for cardiovascular systems, just to refresh your memories, hematocrit is all about like a percentage of like the red blood cell count and stuff like that in the blood. But then hemoglobin is all about the amount of hemoglobin. So hematocrit is abbreviated HCT, whereas hemoglobin is just HB. So if you see the two, like try not to get confused. So hematocrit versus hemoglobin. In your blood plasma, you'll see a major percent of water and proteins mostly, and then you'll see a very, very small amount of other organic material and electrolytes. And so that kind of makes sense. Like your system has a lot of water going around it and a lot of proteins. Again, this is from kind of like the first unit. Never let monkeys eat bananas. The order of how many different immune cells you'll see in the system. So thinking about the heart, just to review. So the right side of the heart feeds into the lungs. So if you feed into the lungs, you have deoxygenated blood. So you want to bring the blood to the lungs to pick up the oxygen, and then it'll shoot it back out to the rest of the system. The left side is all systemic. So it's responsible, once it gets oxygenated blood, to send it to everywhere else besides the heart and the lungs. Okay? So let's run through this. So the right atrium, so atrium is kind of like the top part of that heart. It feeds into the ventricles. And then from the ventricles, you feed into, so between the atrium and ventricles, you have AV valves, okay? And then in the left side of the heart, it's called the bicuspid or mitral valve. In the right side of the heart, it's called the tricuspid valve. And then so right atrium goes to right AV valve or tricuspid valve. Then it goes into the right ventricle, which goes through the semilunar, this is the pulmonary semilunar valve, to the pulmonary artery. So the pulmonary artery is, so arteries think away from the heart. Pulmonary artery tells you where it's going. So it's an artery leaving the heart to go to the lungs. Once it goes to the lungs, that's where you can pick up oxygen. And so arteries, they bring blood like through the arterioles, and then it gradually gets more and more controlled around the capillaries. So you want to take your time at the capillaries, properly exchanging all the blood oxygen and carbon dioxide that you've kind of accumulated or gotten rid of throughout the circulation. And then from capillaries, you go back up through venules, which are like tiny veins, to bigger veins. And then the veins bring it back into the heart. So now we have the pulmonary veins. So veins coming back to the heart, pulmonary where it's from. And then we go to the left atrium, left bicuspid or mitral AV valve. And then AV stands for atrioventricular valve. Then left ventricle, aortic semilunar valve. So the aorta is the biggest valve that you're going to pump out to everything in the body. So that's why the left side of the heart is like this majorly big portion. So left side really big. And then it pumps out to the rest of the system. And then you go to the arteries, arterioles. You're getting closer and closer down to these capillaries. Blood gas exchange. So oxygen gets dumped to the tissue, and then from the tissue you pick up carbon dioxide, and then it kind of circulates back all the way over here through the veins. Okay. So with the heart, you've got a lot of different layers to it. So anything with endo, think like inner. So you've got this endocardium layer that lines all of the blood vessels. It's like on the very innermost part. You've got the myocardium, so muscular part, that's typically the middle. And so a cardiac or cardiomyocyte is the functional unit of a heart. It's a heart cell, heart muscle cell. Then you have this visceral, kind of the outer pericardium, which is also called the epicardium. And so epi meaning upon, so epi is the outermost layer, and then parietal is kind of it borders as well, and that's outside the visceral. It's not stuck or anchored down. So just to show that again, endo, like inside the heart, muscular myo, then you've got these various pericardium layers, and then you've got kind of the fibrous pericardium on the very outside of the heart. And so you have what's called serous fluid that is in between this layer right over here, and that is a lubricant for when the heart is contracting and moving and stuff like that. It's just to make sure that like when you rub up against something, like it's not causing friction and it kind of diffuses out any tension. And then you might see this thing called a cardiac tamponade. So fluid is collecting around the pericardium in the potential space. So potential space is kind of like the space where like it's kind of always empty and you don't want any fluid in there because it, you know, the heart's going to expand, so this space just needs to have that like, you know, breathing room basically. So if you get fluid into that potential space, the heart can't fill properly, and then you'll get some sort of clinical manifestation. And I think that's another one of your clinical cases. So a lot of the clinical cases that you see for these units, like you'll see the actual disease or the disorder kind of come about from like all of his PowerPoints for this unit, whereas I felt like for the first unit, it's kind of, you're not so sure about a lot of them because they're a lot more specific about bacteria or, you know, whatever else. So this one, like, I think it's a lot easier to understand the clinical cases more because you have a better background of like, if this heart problem comes about, like this clinical manifestation you should see. Let's see. So I guess all the major structures that you just need to make sure you understand really down pat. So difference between atria and ventricles, and where are all the different valves. So if you say tricuspid valve, you should know that's the atrioventricular valve between atria ventricles, and a semilunar valve, that's between the ventricles and the either the aorta or the pulmonary side of things. So I would just make sure moving forward that having a good grasp of heart circulation, you should have that before like the next lecture or something so that you can kind of get the most out of it. You have these other things called chordae tendineae, and so chordae tendineae, they are there to kind of hold everything together, and you also have this thing called papillary muscles that are some of the most important muscles in the body because they prevent the valves from inverting during contraction. And so if you did get like an inversion of the valves, then the blood can kind of go different directions, and that can lead to death. And so when the valves invert, that's called a prolapse. So papillary muscles are very, very important. Chordae tendineae are also very important. They're kind of like heartstrings keeping everything together. In the heart, there's kind of two sets of cells. There's conductile cells that send the electrical signal throughout the heart, and there's the actual muscle cardiomyocytes that actually do the contracting. So when you see like somebody talk about like the pacemaker of the heart and things like that, that's all about the conduction system. So the pacemaker of the heart, it's regardless of what the brain is signaling, it will always just keep contracting. So the main pacemaker of the heart is the sinoatrial SA node, so it's up here. But the AV node and the other cells can be your pacemaker if the SA node fails. So blood, or the way it contracts is from the SA node, it sends a signal, goes to the AV node, takes a little bit of a delay, and then it kind of branches down these bundle branches, or a bundle of His is what it's called, and then it kind of comes back up through the Purkinje fibers, and then after the electrical signal goes through, that's when the actual heart will contract. So the atria contracts, then the ventricle contracts, because that's kind of like the start of the electrical signal is up at the top in the atria. So these contract, then it kind of travels down here, and when it travels down here, that's when the ventricles can contract. So
It's not important, but what causes the SA node to fire?
it's just kind of like programmed to just automatically always fire, and then like the AV node also has like this inherent firing capability, but it's slower, not as powerful as the SA node. So the SA node is like your primary pacemaker, and if it fails, some other cell may or may not pick up the slack. And you'll learn more about that in, I think, 2 lectures, maybe 1. So when you look in EKG or electrocardiogram, ECG, same thing, you have different like segments, and so that it all refers to kind of like the electrical conduction that we just talked about. So the P wave is the first thing that comes about, and that's atrial depolarization. So like it's the first like kind of like first movement. So that originates in the atria. Depolarization is kind of think contraction in this case. Then you have this QRX complex. So like as the signal is traveling down the the bundle branches and going around the ventricles, you have ventricular depolarization, and then a T wave back here is when the ventricles kind of repolarize, they get back into normal position, and depending on different segments of how you break it down, you could have different things. Like the PR interval is atrial depolarization plus AV nodal delay. So remember, from the SA node, it contracts, signal sends down to the AV node, it takes a delay, and then it kind of spreads out to the rest of the system. You have a thing called the isoelectric period between the ST interval, and then lastly you have a QT interval for just the action potential duration, so kind of like from here to here, so when the actual ventricle is contracting and getting back to normal. With EKGs, so again, this is just basically showing the same thing, so it kind of puts things better into perspective. So SA node kind of corresponds here, ventricular depolarization, stuff like that, originates from the AV node over here, and then repolarization is kind of all along the ventricle portion for the T wave. Let's see. Yeah, so Q, signal is moving down bundle branches, S kind of getting back to baseline. So now moving on to the phases of the cardiac cycle. So the way to think about it is, where's the blood? And then how do I get blood from point A to point B? So let's first start with atrial systole. So with atrial systole, that's also called the atrial kick. So what happens is, so let's assume that the atria is already pretty full, and it's kind of emptying out into the ventricle, and the ventricle is almost completely topped off. At this point, the atria has this atrial systole, this kick, where it pumps that last bit of blood into the ventricles, and the ventricles are now pretty much topped off. They're at their max capacity for how much blood they're going to pump through. At this point, you don't need to fill it up anymore, so it's isovolumetric, and you're going to start contracting when it's full. And so that contraction with like the constant volume is going to increase the pressure on the cell, on the heart. And that increased pressure eventually is going to put so much pressure that like pressure from up here in the ventricles is higher than below in the aorta. And so that valve, the semilunar valve between the ventricles and the aorta is going to collapse and open up. So think like if I put a heavy weight on like a sheet of paper, the paper would like, snap open or something like that. So like when you have the increased pressure from above, it's going to push down on the valve, cause the valve to open up, so blood can now rapidly eject. So blood rapidly ejects through the aorta throughout the systemic circulation, and then it kind of like goes back all the way out, and then the ventricle has to kind of relax again. And relaxing is diastole, whereas systole is the contraction. And then from there, you can have more filling again, passive filling. So after you've relaxed, get back to a baseline, the ventricular pressure is going to be less than the atrial pressure. So because atrial, which is above, it has the higher pressure, it's going to open up the valve, blood is going to fill in into the ventricles, okay? So it's all about, does point A have higher pressure? If so, it's going to open the valve and allow blood to flow from point A to point B. And then it just kind of keeps circulating all the way around. And typically we talk about the left side of the heart more for like the thinking about the cardiac cycle, but like the right side is basically the same thing, just with the left side you go to the aorta, whereas with the right side you go to the lungs, pulmonary system. So this chart is, you don't have to memorize exact numbers, but it tells you kind of like more conceptual of like, if you have the atria, at some point it has a higher pressure. So let's say the mean pressure is 4 millimeters of mercury. The ventricles, let's say their mean is also 4. But at some point, this 4 from above has to be higher than this 4 and below so that the blood can actually flow from here to here. Or, same thing, atria to ventricles. So 8 versus 7. So at some point, the atria has to have a higher pressure than the ventricles so that the valve can open, so that blood can flow in. Same thing with the ventricles compared to the aorta. So if we have a systolic pressure of 130, aorta could have a pressure of like 120, 140-ish, that range. But at some point, the ventricular pressure is going to peak higher than the aorta is peaking so that blood can go through down into that system. Right, so if we look at the Wigger's diagram worksheet that I handed out to you guys, and I'll also email out a copy of the worksheet, but to break it down, the way I approach Wigger's diagram, just pick a spot that you're comfortable with that makes sense conceptually, and then you just kind of gradually work your way through it. On the test, you may see like 2 questions or something that's like a version of the Wigger's diagram where different points on the diagram are labeled like 1 through 7, and then he kind of gives you random like, is it 1, 3, 5, or 7 that corresponds to atrial systole or ventricular or whatever. And then so those questions, as long as you understand the concepts and like all the little dips and turns of Wigger's diagram, it should make a bit more sense. So let's see, let's start with when the aortic valve opens. Okay, so like right over here. So you have this thing called rapid ejection. It's a rapid ejection because the aortic valve, which is between the ventricle and the aorta, it just opened. So the ventricle was super full, and now it's at a super high pressure. So it's gonna rapidly rush out. Think like if you had a large bucket of water and you threw it, it's gonna like all come out all at once, and then any like residual water that's left in the bucket afterwards, that trickles at the end. So you start with this rapid ejection followed by a reduced ejection. And so you see here that the pressure of the ventricular pressure starts to kind of decrease, and when the ventricular pressure is under the aortic pressure in red up here, then the aortic valve will close, and that corresponds to your S2 heart sound, okay? So now you've reached kind of your minimum point of how much blood is in the ventricles or in the system right now. And so from here, blood has to start building up again, and sorry, the mouse keeps disappearing. So left atrial pressure at some point is gonna increase above the ventricular pressure here, so that the mitral valve, which is between the atria and the ventricles, opens up. So blood comes from the atria down into the ventricles. Okay, so now you start filling up the ventricles again, and from there you can, do the filling of the heart. So with filling, you can have like rapid filling of the heart up here, and then you have this reduced filling. And then imagine it, were to connect and repeat itself. So now we're over here. So to top off that final bit of the heart, we have the atrial systole, the atrial kick, to top off the ventricle. And so the ventricle is filled to like its maximum capacity, and now we can, proceed. So when you're filling the ventricle, you want to make sure the mitral valve is closed at the very end, like once everything is all kind of maximally full and stuff like that. So when the mitral valve closes, you get the beginning of the S1 sound, okay? And so with the S1 sound, that also is kind of corresponding with the tail end of this QRS complex. So QRS, remember, is when the ventricle depolarizes, it's contracting. So it contracts to apply pressure on the in the ventricle. So the ventricular pressure is higher than the aortic pressure. So the valve opens up and then rapidly fills, and then reduced filling, etc., etc., etc. Okay. Yeah, and then you can also watch this animation to kind of orient yourself, but it's basically the same thing. So like some sort of contractile signal kind of goes down and around, and then you get the actual contraction of the heart. Yeah. So this all pieces it together. Okay. So any questions about general like heart circulation or directional flow?
Example? I haven't looked at the test yet.
Mhm,
But
mhm.
is there an example?
So like one example might be if I labeled this point a 7, and the question could be like, what is labeled at point 7? And then he might be looking for mitral valve closes like at this point or something like that. Yeah, something similar to that. Or for example, like mitral valve is opening, at this, where does the mitral valve open? 1, 2, 3, 4, 5, 6, 7, and 7 might be here this time. And then you would just pick that one. Sometimes they're a little bit close, like the two numbers are close to each other, and I would look at the practice tests and see if you can kind of discern between the two, and just look where the pressure lines are, is this one above this one? And there's slight nuances, but if you have like this Wigger's diagram annotated and you're familiar with it, then like it shouldn't be too bad.
What exactly is the difference between chordate and papillary muscle? Like I know that like they're kind of doing the same thing, but is there a distinct difference between their functions? I mean, I kind of wrote down that they both keep the valve from operating.
Yeah, I would say the papillary muscles are more for the actual valve, like making sure the valve is like staying put, whereas like I think my understanding of the chordate tendonae is that they're more like for the holding the actual structures kind of in place when they're contracting and stuff like that. Yeah, so one is more valve specific and one is more general, like holding the heart together. Yeah. Okay. So there's this other thing called the Frank Starling's law of the heart, and this is just kind of like a fancy chart to kind of say like how do you change up like what you're doing to get where you want, sort of. So let's see. If you have, so there's this concept called a preload, and that's how much volume you have starting in the ventricles. Okay. So we'll orient ourselves within the left atrial and ventricular systems for talking about this to make it a little bit more clear. So if I had a large volume of fluid starting in the ventricles, then I might pump out more blood because it's, overly full, or like it's just like a stronger force or something like that. But you might have decreased preload due to some sort of sorry, where is the mouse? Okay. There we go. So you might have like a decreased contractility or decreased preload, and that would affect how much blood you effectively are pumping out. So an example of increased contractility, so how much or how strong you can actually pump, that's with exercise. So with exercise, you contract harder because you need to kind of get the blood flowing a little bit faster, a little bit more quickly, because you're in the high energy state. Whereas with decreased contractility, that might be because of like heart failure, or something where your heart physically isn't able to pump out as strongly as much. Moving on to circulation. So again, arteries go away from the heart. They go into arterioles, which are a little bit smaller, more controlled. Then into capillaries. Capillaries have like some excess like fluid sometimes, and that excess fluid can drain into the lymphatic system, just so you can find like antigens and process different things. And then from capillaries you move into the venules, which are like small veins, into veins, big veins. So this chart is kind of telling you like how things are moving in the cell. So like large arteries, high pressure, like you rapidly get blood going to where it needs to go. So his example is that they're kind of like the highways of your circulation. So quickly get where you need to go. And let's, for example, say we're slowing down, kind of getting to more local roads as we go along from the medium-sized arteries to the arterioles. And now we're pulling up into, the parking lot, so the capillaries. And here we're going to go into the, the gas exchange store, where we're going to pay oxygen and pick up some carbon dioxide from tissues. Okay, so we're going to give oxygen so that the cells have enough to get energy and stuff like that with the oxygen, and they don't need carbon dioxide in the system, so we're going to just clear it out. And so now, we get back onto the local roads with these venules, and then we kind of, take our time going away with our carbon dioxide back to the heart system. Okay, so high pressure and speed from the arteries, slowing down for proper nutritional exchange, and also getting rid of the waste at the capillaries, and then kind of picking up the pace, just kind of, taking it easy, like once you've done the exchange. Right. So, arteries and veins, they have a inner layer called the, or they have one layer called the tunica intima. They have a tunica media, which is kind of the middle, more smooth muscle layer. And then they have the tunica adventitia, which is the outermost layer. And then from those blood vessels, you also have what's called the vasa vasorum, which are blood vessels that actually feed these blood vessels. So in the arteries, in your adventitia level, for large arteries, it's pretty thick, that outermost layer, and you've got a lot of muscle, basically. Some smooth muscle, a lot of elastic fibers, a lot of like contractile force behind it. Next, we've got the medium muscular artery. So you've got a lot of smooth muscle, some elasticity, because now it's just kind of like muscling the blood along. You don't need as much of that outer adventitia layer. And then lastly, you have in the arterial, it's pretty thin, like almost no smooth muscle, very thin or absent adventitia. It's not much like elasticity either, because you're basically branching into the capillaries. So veins and venules, they typically have a larger lumen and a thinner wall. but less pressure than arterioles because you've delivered what you needed to deliver. Now you can just take your time kind of getting back to the lung area. This picture is talking about how blood can circulate in different parts of the body. So there, in case 1, you have arterial going to capillary going to venule and vein. So case 1 is pretty normal. Case 2 is a little bit different because we've got what's called an arteriovenous anastomosis. And so there's no capillary bed in this case. And so you have an arterial going straight to the venule. And so that's an example is in the skin, and that's physiologically okay. That's fine. Sometimes though, like, so this is an okay example of seeing like blood going straight from the artery to the arterial to the venule. Next, you have these other capillary beds, like in 3 and 4. So type 3 is the arterial portal system in the kidneys. So you first have to circulate, so the kidney doesn't drain straight to the portal vein, it goes back into the vena cava. So like blood here goes through an extra capillary bed, extra filtration, stuff like that. And same with the venous portal system in the liver. So the kidney and the liver are 2 points of filtering the blood. Kidney is more like the small stuff that you're going to excrete into the urine, like small electrolytes and stuff like that. And then the liver is more like detoxification, so like large proteins breaking down proteins into amino acids and toxins and stuff like that. So those are the 2 places where you get these like extra capillary beds, and that's what the portal system refers to. So in general, arteries, thicker walls, smaller lumens. Veins, they have valves, which is important to note, so that the veins, like the blood is unidirectional, it's going back into the heart system. Also, I think he mentioned that like for your feet, blood flow to the feet can be, because it's so far away from the heart, like sometimes your blood, it kind of like, it'll pump once to get it kind of like halfway there, and then it pumps again to like get it the rest of the way. It doesn't have to be like one huge pump all throughout the system. So capillaries, there's 3 kinds. There's a continuous, a fenestrated, and a sinusoidal. So with the continuous capillaries, that's the most common. It's pretty much everywhere. Fenestrated though, those are a little bit more different. They're kind of like windows, and it's a rapid exchange of water and solutes. And you see fenestrated capillaries in the kidney and intestines. And then lastly, sinusoidal, they're wider, they're discontinuous, because it allows for some leakage of like different proteins and red blood cells and stuff like that. And so you see that in the liver to make plasma proteins, the bone marrow to make red blood cells, the spleen, and the spleen is where you recycle your red blood cells. So the way the spleen works is red blood cells will go through, and if they don't properly get from one end to the other, it means they're not really healthy enough anymore. They're not really as quote-unquote young. So any ones that don't get through before the spleen kind of like, like engulfs everything, and like, or technically the macrophages are kind of catching up to the red blood cells, then those get all like taken out and eaten up by these macrophages, and then only new, very young red blood cells can escape the spleen and circulate the blood system.
Sorry, what are those numbers? The tenuous and the fibula?
That's just like a relative size. So the U should be like a micro symbol, and it's just like a general like sinusoidal, so wider lumen, 50 to 100, versus the continuous, they're kind of the small, more general size. Yeah. So this picture is all about like net blood flow, and the way I think about it is, if you guys remember back to the edema stuff back in the second PowerPoint, so you have like this hydrostatic pressure and an oncotic pressure. So remember, hydrostatic pressure is pushing outward. So in the capillary end, we're pushing blood out to the interstitium, versus we're not pulling as much in, or we're not trying to pull it back in osmotically, we're trying to get it to the other side. So we have a net filtration of a +10 outward. Then on the capillary going into the venous side, we have a pressure going in, but we don't have a big hydrostatic pressure, so we actually have this net negative filtration. So blood that has been filtered through that interstitium can filter back into the venous system to go into the pulmonary system and pick up oxygen and stuff like that. So the hydrostatic end is pretty high in the arterial side, and then it's lower on the venous side to facilitate that circulation. And then lastly, our equations that I would throw onto the cheat sheet. He will just ask a very straightforward calculation. So like he'll give you any of these numbers or whatever, and then he'll say like, what is blank? And it's not like anything complicated, it's just plug and chug. So stroke volume, how much the left ventricle actually can pump out per beat. So it's the filling amount, so how much in the left ventricular end diastolic volume minus how much is actually being ejected, and systolic volume. Cardiac output, so that's how much the heart is actually pumping out, so that's the stroke volume, so how much you pumped out per beat times your heart rate, like how many beats per minute. Ejection fraction, 60 to 70% should be normal, and that's the stroke volume, so how much you pumped out per beat over how much is actually there. Pulse pressure is the systolic pressure minus diastolic. Let's see. And then mean arterial pressure MAP, that's the cardiac output times systemic vascular resistance, or it's 1/3 the systolic plus 2/3 diastolic, or it's diastolic plus 1/3 pulse pressure. So you want to make sure that, let's see, never mind. So the, lastly, the systemic vascular resistance is the MAP divided by the cardiac output, so pressure over output. So it's the resistance that the heart actually has to work against, so how difficult it is to get blood back into the vena cava. And there's this thing called Ohm's law, which relates pressure equals flow times resistance, and that's kind of this here. And then we have how do you actually control the cardiovascular system. So the goal is, do we have sufficient blood flow, or do we have comfortable blood pressure? So either of these factors kind of control these four quote-unquote levers of the cardiorespiratory center in the brain. So you can have increase chronotropically, and that's heart rate. So I can increase my heart rate if I want to increase my cardiac output and increase my blood pressure. I can have inotropic regulation, so how hard the heart is actually beating. So if I increase how hard the heart beats, I can increase how much is ejected, the ejection fraction, and then I can increase the cardiac output and blood pressure. Then there's the systemic vascular resistance, so how much resistance the heart actually pumps against. So if I have increased resistance, I don't really pump out as much, but because it's harder to pump against that pressure, the blood pressure will go up. It's hard to pump against that resistance, sorry. And then lastly is your central venous pressure, which is how much actually kind of like comes back into the heart. So if you have more pressure, then you have more coming back into the end diastolic volume. Then you can pump out more stroke volume, pump more cardiac output, and the blood pressure. So if blood returns to the heart, you're increasing preload. And remember, if you increase the preload, you can pump more out later. So the sympathetic nervous system increases all of these and regulates them with epinephrine, norepinephrine, and dopamine, whereas the parasympathetic nervous system decreases it with acetylcholine. So they work opposite of each other. So sympathetic is like energizing and fight or flight, whereas the parasympathetic is resting, digesting. And that concludes it for today. So does anyone have any questions before we conclude?